Good afternoon, everyone. Thank you for joining us. Today is our first session discussing the rural emergency hospital designation. This will be laying the foundation, kind of talking about what we know now. This is a very hot topic, and this is one that's been really, I've mentioned on our site visits, this is one that it's been the focus of a lot of our meetings, national meetings, calls, etc., over the summer and into the fall. And so we wanted to provide as much information as available. Jonathan and Greg will be presenting today. They'll be going over the proposed rules, what we know now that were released. I think it was about the middle of July. We are anticipating the final rules from CMS to be released before the end of the calendar year, but hopefully sometime in November. And so we're planning to do another session in November of what we know now, what is confirmed. And so this one's really just to kind of provide the information and then get your feedback, kind of talk about what your next steps would look like if this is a model you're interested in looking more into. We are, as always, informal. So if you have any questions, comments, please feel free to put those in the chat or you have control over your microphone. So if you want to unmute, feel free to do so as well. I will be watching the chat. With that said, Jonathan, I'll turn it over to you.
Thanks, Laura. And as Laura mentioned, what we really want to talk about today is the Rural Emergency Hospital. Now, coming under the realization that this is a new designation from Medicare, and it was established as a part of the Consolidated Appropriations Act. Now, as we walk through today, again, we're very much going to advise and discuss the different information that we know to this point. Now, the designation was passed as a part, again, of that Consolidated Appropriations Act, but many of the final rules have not come out yet relative to this program. So as we talk through the things today and we get into some of those different proposed rules, these are the things that we know at this point. Now, many of those things could change. They could end up overlaying in different regulations or so forth as we end up going forward. But it's important to gain a more comprehensive understanding as to how this program will play out and how it will impact organizations going forward. Now, real quick, before we jump into the information, many of you are probably noticing a new company name on the bottom right. Greg and I, we used to be at Stroudwater, and we actually established a new firm, Wintergreen. So that will be a name that you do see throughout the presentation today. But Greg and I have done a significant amount of work across Oklahoma in the past few years. So we do have relationships with many of the organizations. Now, as we talk through the information today, what we're going to first go into is a policy background, and Greg will provide additional information as to what the landscape looked like prior to this, how we really got here, and talk about the different parameters as to what we're looking at going forward. Again, this is very similar to what we experienced with the Critical Access Hospital program when that was established back in the day. So how will this rural emergency hospital potentially play into the future of organizations going forward? Then what we'll talk about is the rural healthcare landscape. Again, as we come out of the COVID pandemic and realizing that we're in an environment of increasing costs and stagnant reimbursements, what does that mean for the rural landscape? Again, are we in an environment that we can easily sustain services, or are we in an environment where this new designation can ensure the continued providing of services going forward due to, again, those cost increases, declining reimbursements, provider issues relative to access to care, and so forth? Then we'll go into the rural emergency hospital and provide an overview. Again, what was passed in the legislation? What are the things that we know to be true at this point? Then what we'll go into, which is really what many of the people are more concerned about, is the unknown. What are the specific program parameters? How will it play out? How does it impact things such as 340B and swing bed services and ambulance reimbursements and so forth? All of those things that were not addressed as a part of the legislation, and many of the things that have also not been addressed as a part of the proposed rules thus far. So again, this is a new program. There are things that are going to be worked out not only as a part of the final rule that will be coming out, but also things that will need to be addressed in the coming years. Now, one of the core things that we want to state as a part of this presentation and to really kick things off, any organization that's looking at pursuing this designation, Again, this is a material change for your organization. It'll not only impact the services that you can provide, but also how you can provide those services and the financial position of your organization going forward. So any organization that is potentially evaluating the rural emergency hospital, we just want to ensure that you do know that we have to do, or you have to do, full analysis to ensure that you're making the right decision. Again, we don't want any organization to be put in a position where they're either having to reverse, or they got rid of services, or it puts them in an unsustainable position going forward. So now I'm going to turn it over to my colleague, Greg Wolf. And again, he's going to talk more about the policy background involving the REH and really the general healthcare environment.
Thanks, Jonathan. If you could advance to the next slide. Where I wanted to start was 25 years ago. It's been 25 years since the last major new hospital CMS designation was created as part of the Balanced Budget Act. And that was created as a result of a spate of hospital closures, particularly mid to small size hospitals back 30, 40 years ago. And in response to that, a bunch of the policymakers, including NRHA at the time, sought and was granted the creation of a new designation, the Critical Access Hospital. At the time, there was uncertainty over whether or not these really small and principally rural PPS hospitals would embrace the new designation. The American Hospital Association, in and around 1997, estimated that there might be 300 of these very small rural PPS facilities look into and convert from PPS to critical access. Turns out that over the last 25 years, we've had way more than 300 convert. And I offer that as an observation because it's been 25 years, but now we have a brand new designation, REH, has not gone live yet, but we have seen a bunch of recent closures of hospitals. We've seen health policy in our country transform itself inside and out, probably several cycles over the last 25 years. We find ourselves with a new reality. So if the best guess was 300, and then we ended up with over 1,300, we have to have a pretty sober eye toward what our best guess is today for how many REHs we will eventually have. And nobody really knows. Next slide. The best guess in sort of the parlor game that I've played over the last 3 or 4 months, and these numbers have changed, the best guess is around 67. It's a number that was provided to me by one of the key architects of the critical access hospital designation. Now that number itself is higher than it was even a couple of months ago when we found out that the admin payment from CMS was going to be over $3 million. That number went up. But if you apply a little bit of arithmetic, we could easily be looking at up to a couple of hundred REHs. So the expectation has really changed even recently. It's anyone's guess where we'll eventually land on this, but it's a very legitimate option for many organizations and something that we think people need to be taking probably today more seriously than we would have expected even at the beginning of the summer. Things have changed. And so to it, hats off to Laura and her team for starting this educational process. As Jonathan mentioned, there's still a lot of stuff we don't know. But I wanted to try to open your eyes to the idea that this is a very, very real, tangible opportunity for many organizations, and we're expecting that will have quite a few critical access and some small rural PPS hospitals convert to REH. Next slide, Jonathan. So here's where we are from a timing standpoint. We're really at the beginning stages. We're waiting for the final rule to be let out, and we're hoping that the final rule covers the growing list of questions that remain from an operational and from a regulatory standpoint. By the end of this month, the Federal Office of Rural Health Policy will be announcing the name of the organization that will be awarded a grant to serve as the multi-year TA center. Its scope of work is still a little bit ambiguous, but ultimately the TA center will be responsible for supporting states and hospitals and health systems in getting candidate hospitals lined up with applications to become the new designation of rural emergency hospital. While we are looking into that and the TA center is getting named and we are patiently waiting for the final rule, we're also waiting for every state to set up the hospital license so that hospitals that do the analysis and determine for a variety of reasons, political, cultural, financial, that they're interested in making the change mostly from critical access to rural emergency hospital, that the state has the license in place to facilitate that. We think that though the hospitals will really fall into two camps. There are those organizations that have already started the financial feasibility work to determine the impact of what the reimbursement change would bring to their community and to their organizations. And then there's a second group that we think will come online a little bit later, certainly after we think the issuance of the final rule. And those are organizations that probably 3 or 4 months ago, absolutely they were just not interested. It's not a good fit. We're too big, we're doing okay financially, not interested. We think there's going to be an entire tranche of hospitals that say, well, wait a second. We hitherto did not feel this was going to be at all a good fit for our community or for our hospital. We think there's going to be a new group that at least feel the responsibility to do the due diligence, if for no other reason than to rule out and report to the board why, from a quantitative and empirical perspective, why this would not make sense. So our sense is there's going to be a lot of hospitals that are taking this option more seriously. Again, in some cases, really as a definitive rule out, but not just sort of gut check decision and sort of reflexively saying this isn't going to make sense. We're not even going to take the time to look at this. But as I mentioned, we've got a growing list of hospitals that are already seriously looking at this, because in some instances, if you look at a hospital like Bucktail Medical Center in Renovo, Pennsylvania, the $3.2 million payment from Medicare actually exceeds how much money they got from Medicare last year to begin with. So there are some super, super small, very remote, financially struggling hospitals where this seems like it makes pretty good sense. So just as a heads up to the group. Next slide. The criteria, the candidates for REH to us fall into 3 very often interacting criteria. One is performance. How well has your hospital done financially over the last several years? COVID makes things very complicated because your performance during the pandemic may not be a very good indication of how you had performed prior to the pandemic or what things look like coming out of the pandemic. And do we have another season with variants facing us, which makes the guesswork or the modeling even more complicated, but still work that needs to be done. Scale. Do you already have a very low inpatient census, whether it's general acute or swing beds? are you already a very small hospital? And I think that the smaller you are from a legacy perspective, that would be something in the pro column for you to consider, REH. And then if you're part of a system, this new designation provides another arrow in the quiver of multi-hospital health systems to look into configuring their broader regional delivery system. And so we're expecting hospitals that typically have not been performing very well financially over the last several years, that by their very nature, perhaps a function of the market and their service area, are not particularly big from an inpatient census perspective, and ones that are part of health systems where the strategic opportunities to think more creatively around configuring different provider profiles across larger geographic regions, there's just more options there. So those are the things from our perspective that we're looking at to see which hospitals seem like they might be pretty good candidates for this. So I think that's the last slide that I have, Jonathan. I think that takes you into the landscape. I don't know if we want to pause and see if anybody has any questions as we try to set the table and try to figure out where things are right now.
All right, not seeing any questions come in yet. Again, if there are any questions, please do not hesitate to either unmute yourself and ask, or you can submit them in the chat box, whatever works best for you. Now, as Greg had mentioned, again, what we've seen through the pandemic and also before the pandemic is we've really seen a change in the healthcare landscape. And many of these rural providers have been struggling since long before the COVID pandemic. Now, if we look across the country and we want to look at those hospitals with truly a low margin position, what we've come to realize is that there are not very many hospitals across the country that are in a truly financially advantageous or solvent position. And again, particularly when we're looking at rural communities, what we're coming to realize is many of these rural communities are operating on margins close to 1 or 2%. And again, the difference between having to get a couple percentage margin basis versus having a decline in volume can have a substantive or material position on the overall financial performance of your organization. Hold on one second, I see a bunch of questions coming through. Yeah, the slides will be shared. So again, when we look at the position of many of these organizations, particularly in the South and in the Midwest, we've seen many organizations that have struggled in a pre-pandemic environment. Now, as we've made our way across and through the COVID pandemic, what we've all seen is significant cost increases. Again, we've seen declines in reimbursement. We've seen many of the things come to light as we start to see the struggling financial position of many of these organizations. Now, as we look at these organizations also, it's coming to understand what are truly the services that we need within our rural communities. Now, again, if we go back years, many organizations truly tried to be a service provider that could really provide all the services that any patient would need within their community. Now, with the advent of technology and the ability to leverage things such as telehealth and the advancements in technology as a whole, what we've seen is more organizations start to create efficiencies and truly become emergency care providers in many of those rural communities. Again, we're oftentimes sending patients to larger tertiary facilities if they need real extreme or extensive acute care services or higher end acute care services. But again, we continue to see many of these organizations struggling across the country. Now, when we look across the country, and again, I only went back 10 years. If we go back 10 years, there have been nearly 200 hospital closures in the past 10 years across the country. And again, we continue to see this across critical access hospitals. We see it across short-term acute care facilities, sole community hospitals. Now, what we've realized when we look at the critical access hospital program that Greg had mentioned is oftentimes those designations are insulated from many of the changes and the impacts that we're seeing across the country. And again, because they have that cost-based nature for many of those Medicare services that are qualified as a part of that critical access hospital, oftentimes they're insulated from many of those issues. But nonetheless, even though there are those reimbursement advantages, we continue to see many rural providers close across the country. Now, as we look out through 2019 and 2020, we had 18 and 19 hospital closures in those two states. In 2021, we did see a significant decline, going down to 2. And that was really driven much because of the advanced payments that were given to organizations, and then also the supplemental income that was given to them through the way of PPP loans and other type of COVID-type pandemic funding. But nonetheless, we are expecting to see a further increase in the number of hospital closures as we look out, as we get back into a normalized environment. Again, because of those significant cost increases that we've experienced over the past couple of years that are most likely to be unresolved going forward. It's unlikely that we're going to see a drop in the cost for staff or a drop in the cost for supplies. What we're experiencing now is most likely going to be the normalized environment going forward. Now, we may be able to realize certain hospital efficiencies. We may be able to get rid of our traveler nurses. We may be able to reduce some expenses, but most of those core expenses are going to remain static or continue to increase in the future as we look at the services that we're providing. Now, I realize that we're focusing on hospitals today, but what I really wanted to look at was use this slide to emphasize the costs that many of our facilities are experiencing across the country. Now, to focus specifically on the rural health clinics, we ended up pulling all of the cost report data going back to 2015 through 2020. And what we wanted to look at is what is the average annual increase that our facilities are experiencing, and how will that play out into the future? Now, if we look in prior years, we could see that the cost increase was 5, 6, and so forth %. However, by the time we got out to 2020, whether you were an independent or a provider-based rural health clinic, you experienced a cost increase near 20%. Now, even if we're able to dial this back to the annualized impact of about 7%, how many of us long-term can sustain services as a hospital if we continue to experience, say, even a 5 or 6% increase relative to where our reimbursements are going forward? So again, we're really going to have to take a look at the services that we're providing, how we can continue to provide those services going forward, and start to evaluate what truly are the services that our community needs and how we can provide those services going forward. Again, the ultimate goal is the sustainability of service and the access to care going forward for these patient populations. Now, again, if we just look at the impact from a negative position going forward, what this map emphasizes is those organizations that, again, will be negatively impacted because of the change in the reimbursement structures going forward. So whether it's a commercial payer, whether it's a Medicare payer, whatever the case may be, all of the organizations on the payment side are looking at ways to cap reimbursements going forward. In addition to that, because we are experiencing those cost increases on the other side, again, we really have to start to look at opportunities to provide services going forward. Now, what this slide really focuses on is it looked at all of those practices or all of those hospitals that were in the bottom 10% from a margin perspective of performing hospitals back in 2017. And what it looked at is it broke it down between rural hospitals and urban facilities. And what it wanted to look at is if those rural hospitals and urban facilities were to close, how far away is the next closest facility that could provide access to emergency care? And when we look at those numbers, what we found is that if an urban facility is to close, if that facility closed, 52% of those facilities are within 5 miles of the next closest facility. As we start to look at our rural providers, we can see that if we go out to those that are 20 to 35 miles away from the next closest facility, 45% of our rural hospitals are at least 20 to 35 miles away from the next closest facility. So when we start looking at all of those hospitals that are providing emergency services, diagnostic imaging, lab, and really focusing on those that are in the bottom 10% of margin facilities, we start to realize that many of our hospitals that are serving these rural communities, if they were to close, patients would have to travel significant distances to just receive the most basic emergency care. So again, it's starting to look at all of those different factors as we go forward. Now, jumping into the rural emergency hospital, again, this designation was passed as a part of the Consolidated Appropriations Act of 2021. And really the intent of the program was to provide an alternative designation, realizing that many rural communities are starting to see a decline in their inpatient volumes. And as we continue to see a decline in those inpatient volumes, do all rural community hospitals truly have to be in the services of providing inpatient care? And what they wanted to do was they wanted to create a designation that would allow those hospitals to continue to provide those core services in rural communities in exchange for giving up those inpatient beds. Now, again, when we talk about inpatient beds, it's really around the inpatient acute care services. Again, your rural emergency hospitals still can provide SNF type services in a distinct unit. You can provide observation type services in an outpatient setting. Again, it's getting up those acute ICU, truly inpatient type services. Now, the Consolidated Appropriations Act established certain requirements for that designation. And it really came down to three core areas. Came down to eligibility, it came down to the overall requirements, and then it also established reimbursement for those different facilities. Now, it's important to note that the Secretary of HHS was granted or given the authority through the Consolidated Appropriations Act to establish additional requirements for the rural emergency hospital. And as Laura had mentioned at the start of this presentation, those are many of the things that have come out as a part of the proposed rules, a part of those OPPS proposed rules. Now, again, the core requirements cannot be changed unless there's legislative change, but the Secretary can overlay through CMS a number of additional requirements onto those that are wishing to pursue the designation. Again, everything from the application process to additional requirements and so forth. Now, as we walk through next, first what we're going to talk about is give an overview of those requirements and those parameters that were set as a part of the Consolidated Appropriations Act. Again, these are all the things that are kind of set in stone. Then what we'll talk about is the unknown, the things that are in the proposed rules, the things that haven't even been discussed yet, and all of those different factors. So the eligibility requirements. Now, there are two types of facilities that can qualify or pursue the rural emergency hospital designation. They are critical access hospitals and rural hospitals with fewer than or less than 50 beds. Now, as Greg had mentioned, the Critical Access Hospital Program was created in 1997. And this is a unique and distinct designation available to hospitals that meet certain requirements. Again, you have to be a certain distance from other facilities, and you have to meet all of those conditions of participation on an ongoing basis. But critical access hospitals can pursue the REH program. Now, rural hospitals with less than 50 beds, there are several designations that could be considered a rural hospital with less than 50 beds. You could be a sole community hospital. You could be a Medicare dependent. You could be a straight short-term acute care facility, which is your PPS facilities. The key requirement for those is you're located in a rural area and you have less than 50 beds. Whether or not you're a sole community hospital or a short-term acute care facility, that is less relevant than meeting those other core requirements. Other requirements specific to the rural emergency hospital. Now, the first thing you have to do when you want to pursue that REH designation is you clearly have to define as a part of the application process the services that you will continue to retain, the services that you will modify in providing, and then add and discontinue. For example, if you pursue the REH, you'd be giving up your inpatient beds. Are there other services that you'll also be giving up as a part of becoming an REH? That all has to be identified as a part of the application process going forward. In addition, as Greg had mentioned, that admin payment is about $3.2 million per year. You have to identify how the facility or how you will use that additional facility payment going forward. It is not just a blank check to do whatever you want with those funds. You have to have some idea as to how you will leverage those funds. Now, some of the ways that you can use those funds is to support ambulance services or support certain additional other services within your geographic or your regional service area. But again, you have to identify how you will leverage those funds going forward. For the purposes of how it was defined in the law, an emergency department of an REH has to meet certain staffing requirements. First, it has to be open 24 hours a day, 7 days a week. You do have to have a physician or an APP available to provide services 24 hours a day. In addition to that, you will have to meet other staffing requirements as defined in the conditions of participation. Now, it's important to note right now that CMS has come out and stated that they do plan to mirror whenever possible or where possible the critical access hospital conditions of participation. So for instance, certain things where a provider has to be available or on site within 30 minutes of a patient presenting, or diagnostic imaging, or the laboratory requirements. Many of those will most likely apply to the rural emergency hospital. It's just unknown exactly until they publish the final rule, the specific conditions of participation that will be applicable to those rural emergency hospitals. Now, your REHs are prohibited from providing acute care inpatient services. Now, there are some exceptions for your dedicated SNF services. You can provide services in an observation setting, but the core requirement is you cannot provide services where your average patient length of stay exceeds 24 hours or 1 day per year. Also, it's important to note for our critical access hospitals or programs that are providing our swing bed services, your REHs will no longer be able to provide your true swing bed services where you're getting a cost-based payment as a critical access hospital. You would then have to provide those in a dedicated SNF. Just wanted to emphasize that. As an REH, you will have to establish and maintain a transfer agreement with a level 1 or level 2 trauma center. This is important, again, because we will not be providing those inpatient services, and we will be operating as a truly emergency department type entity. They will want to ensure that if a patient presents to your facility that needs inpatient care or further services, that you do have those transfer agreements in place so that you can get the patients to those facilities for that follow-up care or additional care. Organizations that want to pursue the REH have to meet the licensure requirements in each state. Now, it's important to note that right now, Oklahoma does not have a state-approved designation for the REH. Right now, there are only 3 states that do have that designation approved, and I believe it's Nebraska, Kansas, and South Dakota. So even if we want to pursue the designation on January 1st, if the state of Oklahoma has not established a license for that designation, we will have to wait until that designation is established before we can pursue that program. We will also have to meet all other requirements as established by the Secretary of HHS. Again, whether it's the CA conditions of participation where applicable, whether they establish other rules and requirements to that degree. Now, for the purposes of organizations that are operating rural health clinics will be considered grandfathered from a reimbursement perspective if you continue to operate under a REH. So again, organizations that have a provider-based rural health clinic now and your cost-based rate that was grandfathered in is $250. If you convert to an REH, you will can be considered grandfathered for that provision. REHs must also submit quality data as determined by the Secretary of HHS. Again, because there's going to be administrative payment, because there are other factors tied to the reimbursement, there will be the submission of quality data. Now, right now, they are thinking that it's going to be, again, similar to the critical access hospitals and many of the data that they have to submit. But again, it has not been decided at this point. Somebody did ask if I know the status as to the REH designation. I did a check last night and I hadn't seen anything published. Now, it is possible Laura or Corey may be able to speak to this in further degree as to if anything's been finalized or anything's been actually proposed. I hadn't seen anything as of last night. Again, it doesn't mean that it does not exist. Something could have been passed and established and it's maybe just not readily available at this point, but I hadn't seen anything as of yet.
Jonathan, this is Laura. Trent also commented that we do have something in place, but from my understanding is we had a model or a designation possibly available but not activated. Trent, I'm curious if that's what you understand as well, or if anyone else on the call, if that's what you've understood in the past.
Yeah, the OHA stance is that there is a designation available that would qualify as an REH. It may not be stated as REH, but it is emergency hospital.
Yeah, I know that. Go ahead, Laura.
I was just going to say, but it just hasn't really been utilized. Is that your understanding as well?
Yes, that is my understanding.
That's something licensure would ultimately dictate on. For instance, I know in Pennsylvania, they recently passed a freestanding emergency department regulation that established that as a new license. But they came out and said that that could not be used as or for the REH. For instance, in that situation, you would have to go under the CCN of another hospital. So it'd almost be like a remote or satellite facility of. But if there's something out there, that's great. Again, I would just validate to ensure that something is and can be leveraged for that.
Jonathan, just to kind of tag on, as mentioned earlier, there will be the National Technical Assistance Center, and that entity has not been announced or awarded as of yet. But that is one of the questions we have as a state office, kind of right off the bat, because our understanding is that entity will really do a lot of the legwork in helping interested facilities with that process. And so that is definitely a question we have is, you know, kind of statewide, where do we stand here in Oklahoma?
Correct. Now, when we look at the REH from a reimbursement perspective, again, the goal is to have the program go into effect on January 1st. Whether or not you can is entirely dependent upon whether or not, again, you have a designation and you can pursue that program. Now, you do have to go through a full application process to pursue this designation. So the likeliness of somebody actually becoming REH on January 1st is probably pretty unlikely. Just because the TA center is not established, they haven't even finalized the rules and all so forth. Now, payment for REH services will be reimbursed based on the OPPS rate increased by 5%. Payment for non-REH services will be reimbursed at the same payment rate if performed by a hospital outpatient department. So again, whether you're billing for those services, you will get reimbursed for those services. Provider services will be based on the applicable fee schedule. And then REHs, this is again as a part of those proposed rules, the first year, the monthly payment will be nearly $269,000 per month as that administrative or that facility payment. And that comes out to a total annual payment of $3.2 million. So again, as Greg had mentioned earlier, there's many facilities across the country where frankly, their entire net patient revenue isn't $3.2 million per year. And this will be an attractive approach or an opportunity for how they can continue to provide services and truly become more of an outpatient facility going forward. Now, what is the unknown? And I would say right now there is a much greater unknown than there is a known. Now, some of them that are listed are issues that have been raised at the national level. Some have been discussed, but many of them have not been 100% finalized with regard to any of the topics. Now, earlier we mentioned the ability to participate and maintain your designation as a provider-based rural health clinic and still get that grandfathered rate. One of the things that hasn't been 100% finalized is organizations and whether or not the REH will qualify for the 340B program. Now, when we look at the 340B program, again, this provides additional revenue for many organizations across the country and helps them sustain those services going forward. Now, organizations will generally qualify for 340B if you're an FQHC, that's a federally qualified health center, or if you're listed under one of the hospitals that qualify, which is either your critical access hospital or DISH eligible hospitals or other ones identified. This has been raised at the national level. It's unknown what, if it's been done thus far to allow them to qualify for that program. Now, inside the federal law, it also states relative to necessary provider of critical access hospitals, it does state that you can convert back to your prior designation as a CA if you do not or did not want to continue to operate as a rural emergency hospital. What is not 100% clear is how this would play into those organizations that were necessary provider CAs, since that ability to qualify as a necessary provider critical access hospital has gone away. So again, this is something that needs to be worked out at the federal level. The next is around ambulance services. Now, inside the federal law, it says ambulance will be reimbursed in accordance with the Social Security Act, Section 1834L. Now, in Section 1834L, it talks about fee-for-service reimbursement methodology and a specific payment rate that is applicable to critical access hospitals. And again, when we look at the ambulance services under critical access hospitals and meeting the requirements to get cost-based relative to the 35-mile requirement and so forth, it does not address whether or not ambulance services under rural emergency hospitals will be continued to provide under that critical access hospital reimbursement methodology. So again, that cost-based nature for those critical access hospitals that are providing ambulance services often helps subsidize the services for those ambulance services. Now, again, this is an unknown, but based on how the law is written and the guidance so far, the fact that they clearly identify ambulance services as something that can be subsidized through that $3.2 million payment, it's unlikely that they would also provide cost-based reimbursement for those services when they did clearly define that you could use your administrative payment for those services. So one of the questions is, if this program requires you to discontinue swing bed services and your swing bed cash flow is greater than 3.2, wouldn't this program be detrimental to an organization? I wish it was as simple as just yes or no. It could be detrimental to your organization, especially when you start looking at the fact that swing bed services are oftentimes 80% plus cost-based. And when you look at all of those different factors, yes, it could be detrimental to your organization. But again, without looking at the services that you're providing, how you're able to dilute down the cost, and your overall position as a hospital in those different areas, again, it's unknown whether or not it would be detrimental, because again, if you get rid of those inpatient services, you're going to get rid of a significant portion of cost that's also tied to that inpatient unit. You're no longer going to need as much nursing staff, CNAs, MAs, however you're staffing that floor. You're not going to need as many hospitalists. You actually won't need really any hospitalists if you get rid of your swing bed program. So again, it's looking at the cost reductions and the loss in revenue and comparing that to the reimbursement gains that you would get under this other program. Again, also you have to factor, can your organization sustain services in a OPPS reimbursement methodology for those other outpatient services? If you're a low volume emergency department, will you be able to sustain services based on OPPS reimbursement as an emergency department and still provide to cover the cost of those providers and nurses in that environment without the cost-based mechanisms as a critical access hospital. So again, there is no one-size-fits-all approach. It's very much dependent upon the specific services that you're providing.
Hey, Jonathan, in the spirit of there's not one size that fits all, Oklahoma is characterized, at least in one way, by the variation in its use of swing beds. There are some critical access hospitals that really don't use swing beds. They either just have not set them up or they're full with general acute. And then conversely, I know of at least one Oklahoma critical access hospital that I think for the most part only has swing beds and a very robust 25-bed swing bed program. So, this is one of those things where you can't just take a template and drop it in and put some numbers into a spreadsheet and out comes the number. It's going to be some complicated analysis, but I wanted to put it out there. Swing beds is particularly variable in the state of Oklahoma with your cause.
Correct. And again, to re-emphasize, you definitely want to evaluate the net financial impact on your organization before you pursue any designation change. And it wouldn't matter if you were a sole community hospital going to a critical access hospital, a critical access going to an REH. Any designation change, you always want to do a comprehensive analysis to gain an understanding as to not only how it will change the financial position of your organization, but how it will impact the ability to provide services going forward. Next area that's been partially addressed in the proposed rules is off-campus provider-based departments. Now, for those that are critical access hospitals, this will be completely foreign to you, but for those that are operating PPS hospitals, as a part of the Bipartisan Budget Act of 2015, they came out and put in a provision that eliminated the ability to get full OPPS reimbursement for off-campus departments of a hospital. Now, right now, CMS is proposing that your REHs and the services that you provide at that REH in an off-campus setting would not be subject to the payment provisions under Section 603 of the Bipartisan Budget Act. Now, one thing they did not emphasize is whether or not the Secretary will take the position at a future date to apply a site-neutral payment policy to those REHs. And this is something that really hit out organizations in the past when they established that Bipartisan Budget Act and they grandfathered in off-campus provider-based departments that were billing for services prior to 2017. So it is possible that they may take the position in a budget shortfall type year to apply a site-neutral payment policy approach to those off-campus locations. It's also unknown the approach CMS will take relative to those off-campus practices or departments that were impacted by Section 603 or the site-neutral payment policy approach. Again, if an organization is already receiving site-neutral payment policies, will they allow them to get that full APC payment in a off-campus location, or would that REH's off-campus location be subject to that site-neutral payment policy? Again, that's something else that has not been resolved. All of the quality standards relative to the providing services in an REH, again, all of those have not been decided yet relative to the services provided. The application process, again, we will have to file an 855A to go through the application process. What CMS has proposed so far is that the application process will really be a change in designation. They're not going to require a full new application to pursue the REH program. So you would be able to change your status as an organization as opposed to going in and starting the whole application process over. Now, the reason for this is it will save a significant amount of time by going through and allowing a change versus a complete redo for that going forward. The next area that I think is kind of interesting is relative to the self-referral or the Stark law. Now, as many of you know, providers are prohibited from having any ownership or interest stake in a facility where they are also referring services to that facility. CMS has proposed an exception for ownership or investment interest in REHs that would allow providers to actually have an ownership interest in that REH and also be referring services to that REH. Now, I'm sure if they do make an exception, there will be additional guardrails or parameters that are established, but nonetheless, it's important to know that this would be receiving an exemption that many of our hospitals do have in place. And then the last area is around the state licensure. Now, Trent did provide a link in there that does emphasize something that may be able to be used as an REH designation within the state of Oklahoma. Again, if you do have interest, I would definitely reach out and confirm that that can be used as we start to look at this designation going forward. Now, again, I do want to reiterate that if we do look for this designation going forward, it is very important that we conduct and look at the impact to our organization. The intent of this designation is to ensure the continued providing of services for these regions going forward. And the intent is not to put organizations in a worse position financially or to put them in a position where they cannot sustain services going forward. I'm going to pause now to see if there's additional or any questions that we can answer relative to these topics. As Laura had mentioned, again, there is very much that is unknown right now relative to this program. What we do hope to address at the next coming presentation is providing some financial information really around a case study approach as to what could be the impact to an organization if an organization were to go forward and to do something like this. Are they better off? Are they worse off? What does it mean for the ability to continue to provide services going forward? So again, I'm going to pause for a second. Please unmute yourself, submit any questions you may have relative to this topic. Are there any organizations that are actively pursuing this designation? Or is it more today just an informative approach?
Jonathan, it's Greg. I'd like to invite any of the folks who are on the call to, if you go to your last slide, Jonathan, your contact information, open invitation to contact us. Laura will share the slides with you. I think my hunch is we're very early in this process. There is a lot of unknowns. Some organizations may be considering this, but I would suspect that most organizations, even if it did look appealing and you think that you are a candidate, probably wouldn't in this forum be sharing, yes, yes, we're already looking at this and committed, but perhaps in a more discreet and confidential manner, I invite anybody on the call to contact us, drop us an email or give us a call and let us know if there's something we can help you with. If you have any specific questions, we'll be around, for the full arc of this flex cycle to provide the ongoing education and outreach. But we do want to respect the fact that people are still really probably trying to sort things out, learn as much as they can, and start to test whether or not it might make sense. And part of our job is to make sure that we're available to help you with that.
Yes, thank you. And Stephen, thank you for your comment. I'll be following up with you as well. If anyone else has questions or, hey, can you do this or can you not do this? Please feel free to reach out. We wanted to host this webinar today to really kind of get the information out there. We are trying to stay on top of this, and trust me, as soon as we find out who the TA Center is, I have a list of questions already, and we do plan to work very closely with the TA Center. So with that said, as we move forward, please reach out to us with any questions, concerns that you might have. And also we tentatively have our next webinar scheduled for November 17th. Granted, that is based on when CMS releases the final rules. And so once we get closer into November, if we have to move that date, we will be sure to let you know. So thank you all for your time. Thank you, Greg and Jonathan. And if we have no further questions, I'll let everyone get back to their days. But I appreciate everyone's time today.